Hello everyone. I'm Dr. Omkar Sangita Dileprao Sonone from Team AFMG, and today I'm back again with a very important and high yielding topic from entrance examination point of view. That is most your NEET PG as well as your FMG exam. For both of these examinations, definitely this is one of the most important topics from medicine as well as from pathology. So I don't think so. Most of you should be doing mistake in this topic of one or two questions minimum from this topic is a must in each and every examination that has been seen from the last few examinations now. Okay, so I hope all of you, this is a very simple topic. Only the most of the people are afraid of this topic, so they don't approach that. Okay, so we will try to understand this topic in a simpler manner, and I don't think so then you would have any issues solving any questions pertaining to this particular topic. Okay, so let's begin talking about ABG analysis. ABG is nothing but arterial blood gas analysis. Okay, so arterial blood gas analysis will tell us about any acid based disorder inside our body. Why acid based disorders in our body are important? As we discussed electrolyte disturbances in our last chapter, this time why are we discussing about acid based disorders? Because please remember, acid based disorders inside our body, definitely our body needs a homeostasis. As we have studied in physiology, it needs homeostasis or a balanced internal environment. If the homeostasis is not maintained, definitely if the patient is having some acid based disorder, that can be lethal or fatal to the patient. ठीक है ना? So जानलेवा हो सकता है, and that is the reason why studying these acid based disorders are very much important. And talking about acid based disorders, they can land up any patient in the ICU. Okay, and in ICU patients, for monitoring of that particular patient, acid based or the arterial blood gas analysis is a very important tool for assessing their well-being or condition in the ICU. Okay, so that is the reason why we will study ABG today. So first of all, talking about arterial blood gas analysis. So ABG is definitely the arterial blood gas is usually performed on a blood sample in a machine. Okay, but for that, for taking a blood sample, there is a procedure which is to be followed. So for taking a blood sample for your arterial blood gas analysis, the first thing that you need to perform is to perform a Allen's test. What do we mean by Allen's test? So please remember, Allen's test is a test which is usually used to perform, which is usually used to check the patency of your palmar arc. Okay, so I hope all of you are quite aware. From this side, the lateral side, you have the radial artery. From the medial side, you have the ulnar artery. Arteries will give off its branches forming a palmar arc, right? So to check the patency of the palmar arc or if the collaterals are formed or not, to check that, so you perform this Allen's test. What do we do in this Allen's test? So please remember, you try to occlude or block both of these arteries. Okay, you try to occlude the radial as well as the ulnar artery. So what will happen once you occlude both these arteries? Definitely, the patient's blood supply to the palm would be reduced, and that will lead to pallor inside on his palm. Okay, so the patient's palm would turn completely pale if both of these arteries are properly occluded. First thing. Then you will try to release one of the arteries and you check for the flush or redness in the palm. If the flush or redness in the palm is seen, that means the palmar arc is patent or the collaterals are being formed. Okay, so that is important. Okay, the same we will do on the other side as well. Okay, so this is more important, guys, to check for the Allen's test, because that will tell you about the patency of the palmar arc, and then you can move further to take a blood sample for your arterial blood gas analysis. Okay, so once the Allen's test is being performed and the patient's Allen's test turns out to be normal, then definitely you need to take a blood sample. How to take a blood sample for ABG? That is important. Take a normal 2 ml or a 5 ml syringe. Okay, and that syringe, you will not directly take a blood sample like you take a venous sample, because this is an arterial sample and there is a high probability or a propensity that this arterial blood sample will clot. Okay, and this clotted sample will not give you results, or that will lead to errors usually in the report. Okay, so that is the reason why before you take the sample, this syringe or 2 ml or 5 ml syringe is to be heparinized. What do we mean by heparinized? So please remember, you should take some of the heparin solution. You should properly coat the walls of the syringe with that heparin. Okay, that will help the blood to stay in the liquid form. Okay, it will not let the blood clot. Okay, so heparinization of syringe is a very important step that is to be done. And after that, definitely you will go and you will palpate the artery, whether it is your radial artery. So 3 arteries are commonly used for taking the arterial blood gas analysis. The most preferred one is definitely the radial artery. Then it is your brachial artery, and next one is your femoral artery. Femoral artery is usually avoided in cases, because most of the cases, because it can lead to infections. Okay? So that site is not usually very clean, and therefore there is a high risk of infections which can be carried onto the arteries. Okay, so usually we try to avoid femoral artery as much as possible. But if the patient's radial artery or brachial artery is not palpable, then you can definitely go for the femoral artery as well. Or if you need a lot of, like, almost 10 ml of blood sample, then definitely femoral artery can be easily approached. Okay, radial artery or the brachial artery, you need to palpate these arteries first. Okay, so please remember, always try to palpate these arteries either with 3 fingers or 2 fingers, whatever you feel like. Okay, so if you palpate this artery with 3 fingers and you can feel the pulse on all the 3 fingers, okay, you can feel the pulse by all the 3 finger pulse, definitely you are actually in the like on the radial artery properly. Or if you are feeling it with 2 fingers, please remember, you need to feel it in the proximal finger as well as the distal finger. Then definitely you can know that you are on the radial artery properly. Okay, and once you get the pulses on both of the fingers, definitely you can insert the needle. Okay, either usually it is inserted at a 90-degree or a 45-degree angle, and you can go deep inside. And once you go like slightly deep on radial artery, you will get the blood sample superficially, but in femoral artery you might need to go deeper. Okay, because there is a lot of fat over there. So definitely, as you will insert your needle, you will get a jet pulsation in the syringe. Okay, you will get the you will get the blood sample directly. You don't need to pierce it really hard, or you don't need to pull out the plunge. Okay, without even pulling the plunge, you can get the blood sample, and it would be in a jet like or a pulsatile fashion. That means definitely it is an arterial sample, first thing. And second, how to identify arterial sample? First, there would be jet like pulsations in the syringe, and secondly, the blood sample which is collected, it is very bright red in color. Okay, it is not dark red as the venous sample, it would be bright red in color. Okay, so with this, you can take a sample from the arterial blood gas, and definitely after that, apply a cotton. When you once remove the needle, just apply the cotton and hold it properly for 3 minutes at least. Okay, or just tape it up. So this is the proper procedure to take a arterial blood gas analysis in a patient. As I told you, either you will take the radial artery sample or you can take a brachial artery sample. And if even not that, then definitely you can go for the femoral artery sample. Okay? No issues with this, anybody? Then once you take this blood sample, you will definitely send it for the arterial blood gas analysis, where it will be analyzed by the machine, and the machine will yield you result. There would be multiple things on the arterial blood gas analysis. The most 3 important things that you need to look for is definitely the pH of the blood sample. Second is the PCO2 level in the blood sample, and third is the bicarbonate level in the blood sample. Okay? So now to understand this, definitely you need to know the normal values of these things. So the 3 things that you need to look for, as I told you, they are pH, PCO2, and bicarbonates respectively. The first thing is pH. So please remember, the most important thing to decide which acid-base disorder the person is suffering from is definitely the pH of the blood sample. What is the normal pH of our blood? So definitely the normal pH of blood is 7.35 to 7.45. Okay. So please remember, the normal pH or the neutral pH of blood is 7.35 to 7.45. Anything more than 7.45 is considered as alkalosis. Anything less than 7.35 is considered as acidosis. I hope that this is pretty much clear. So anything less than 7.35 is definitely acidosis, and anything more than 7.45 is definitely alkalosis in the patient. No issues with this, anybody? So please remember. Next, if I move further to talk about the other 2 components, that is the PCO2 levels and the bicarbonate levels. So the PCO2 level, normally it is 40 mm of Hg. The normal PCO2 value is 40 mm of Hg, whereas the normal bicarbonate value, it is ranging from 22 to 26 milliequivalents per liter. So now there would be somewhat variations in the values, but this is usually which is given in the Harrison's, and therefore I would rather request you to follow the same one. So PCO2 normally it is 40 mm of Hg, and bicarbonates normally it is 22 to 26 milliequivalents per liter. Okay? Now I need to, before we move further, I need you to just remember 2 most important things. Okay? So please remember, pH will definitely decide whether it is acidosis or alkalosis. But whether it is respiratory or metabolic is to be decided by these 2 components. Okay? So please remember, PCO2 will decide whether it is respiratory acidosis or respiratory alkalosis, whereas bicarbonates will decide whether it is a metabolic acidosis or a metabolic alkalosis. Okay? So please remember, any abnormal value of PCO2 is suggestive of respiratory cause. Any abnormal value of bicarbonates is suggestive of a metabolic cause. So that is clear. Then if I move further, I hope all of you are quite aware, CO2, carbon dioxide, is definitely acidic in nature, right? So please remember this thing. So PCO2 or the CO2 level, CO2 is usually acidic in nature. So whenever the PCO2 levels will rise, the patient will suffer from acidosis. And whenever the CO2 levels will go down, it will suffer from alkalosis, because CO2 in its nature, it is acidic or acidotic. Okay? Whereas if I talk about bicarbonates, I hope all of you are quite aware that bicarbonates are usually alkaline or basic in nature, right? So if they are basic in nature, definitely whenever bicarbonates values will rise, the patient will suffer from alkalosis, and whenever they will go down, the patient will suffer from acidosis. Okay? So these are the two most important things I wish you would remember properly. Okay? Then if I move further to the acid-base disorders, usually they only ask you about the four most important, that is acidosis, alkalosis, respiratory or metabolic. Okay? But partially compensated and totally compensated, they might ask in some cases. Usually they don't, but in some cases, agar unko bahut zyada man kiya, so they can even ask those. So let's discuss about the four most important ones first. So first, if I talk about respiratory acidosis. So first of all, please remember to look for the acid-base disorder first. यहाँ पे acid-base disorder क्या है? It is acidosis. So if it is acidosis, the pH should be less than 7.35. If it is acidosis, the pH should be less than 7.35. And they have given it as respiratory. So definitely which value should be abnormal? So the PCO2 value should be abnormal because it is respiratory in nature. Okay? So now, for respiratory acidosis, the PCO2 value should rise. For respiratory acidosis, the PCO2 value should rise. Why? As I told you, because PCO2 is acidic in nature. So अगर CO2 के values rise होंगे तभी तो patient को acidosis होगा, right? So please remember, if the patient is suffering from respiratory acidosis, definitely the PCO2 value should rise. It would be more than 40 mm of Hg. Whereas here the bicarbonate values would be normal. Okay, please remember, here the bicarbonate values would be normal. Why? Because maybe the patient had just started suffering from respiratory acidosis and the body has not yet started compensation, and therefore the bicarbonate values would be absolutely normal. Okay, अब तक compensation start नहीं हुआ है इसलिए. So here the patient is only suffering from respiratory acidosis. Next, if I move further to another one, that is respiratory alkalosis. So if it is alkalosis, the pH value should be more than 7.45. Okay, the pH value would be more than 7.45. As it is respiratory in nature, so which value should be abnormal? Yes, definitely the PCO2 value should be abnormal. Whereas the bicarbonate values would be again normal. The bicarbonate values would be again normal because compensation haven't started yet. Okay? So now PCO2 values क्या होने चाहिए? If CO2 is acidic in nature and the patient is suffering from alkalosis, that means definitely the PCO2 values have been gone down. The PCO2 is less than 40 mm of Hg. As the acidic component decreases, the patient suffers from respiratory alkalosis. Okay? Moving further now, if I talk about the next two metabolic ones. First, they have given that the patient is suffering from metabolic acidosis. So if I talk about the acid-base disorder, that is acidosis. So the patient is having acidosis. That means the pH value should be less than 7.35, right? Whereas as it is metabolic in nature, so which value should be absolutely normal? So the PCO2 value should be absolutely normal because compensation haven't started yet. And as it is metabolic in nature, PCO2 को कोई लेना देना नहीं उससे, right? So now please remember here what will happen now. So please remember, if it is metabolic acidosis and bicarbonates are alkaline in nature, so please remember bicarbonate value should decrease. If bicarbonate values will decrease, then and then only the patient will suffer from metabolic alkalosis, metabolic acidosis, right? Next, last one is metabolic alkalosis. If I talk about metabolic alkalosis, so it is alkalosis, so the pH value should be more than 7.45. pH value is more than 7.45. As it is metabolic in nature, so again the PCO2 value should be normal. Whereas if I talk about the bicarbonate values, so definitely the bicarbonate values here would rise. Okay, why? Because as we know, bicarbonates are alkaline in nature and the patient is also suffering from alkalosis. That means definitely the bicarbonate values in this patient have gone up. Okay. Now, if I talk about the partially compensated or the fully compensated phenomena, so if I talk about partially compensated respiratory acidosis, again, I'll look for the acid-base disorder first. Here, the patient is having acidosis. Definitely, the pH value would be less than 7.35. 0.35. Okay, first thing. Now, as it is respiratory, so which value should be abnormal? So definitely, as it is respiratory, the PCO2 value should be abnormal. And as the patient is having respiratory acidosis, so the PCO2 value should spike up. So the PCO2 value should go up or they will rise, right? And now they have given that the patient is having partially compensated respiratory acidosis. Partially compensated ka matlab kya hai? The body has started to overcome whatever the acid base disorder it is suffering from, or the body has started its compensation, but abhi tak puri tarah se compensation nahi ho paya hai, right? So if the body has started compensation, what it will do? If the body is suffering from respiratory acidosis due to increase in the PCO2 values, the body will try to retain or reabsorb more and more number of bicarbonates. Okay, the body will try to retain or reabsorb more and more number of bicarbonates from the proximal convoluted tubules of the kidney. If it tries to increase the bicarbonate value, definitely the body will suffer from metabolic alkalosis, and therefore the body will somewhere maintain a normal pH, right? So this is how compensation usually occurs. Okay? So if the patient is having respiratory acidosis, there would be a compensatory metabolic alkalosis in the patient. And this compensatory metabolic alkalosis is done by retention or reabsorption of bicarbonates from the proximal convoluted tubule of your kidneys. Okay? So here definitely the bicarbonate values would rise in this patient. Okay? It has just started rising. But why it is called as partially compensated? Partially compensated इसीलिए बोला जाता है because the pH has not been normal yet. अगर pH normal हो जाता, definitely we will call it as a fully or a totally compensated acid-base disorder. But here the pH is still acidic in nature. Definitely, therefore, we will say that the body has started compensation, but the pH has not been normalized yet. And therefore, it is a partially compensated acid-base disorder. Next, if I talk about a fully compensated or a totally compensated metabolic alkalosis they have given, right? So as they are saying totally or fully compensated, that means the pH should be absolutely normal. So the pH shall be between 7.35 to 7.45. But as the patient is suffering from metabolic alkalosis, okay, metabolic alkalosis ka matlab kya hoga? Definitely the bicarbonate value should be high. Okay, if the patient is suffering from metabolic alkalosis, this means the bicarbonate values in his blood would be high, right? So to compensate the metabolic alkalosis component, the patient's body will definitely try to do a respiratory acidosis. So if the patient is suffering from metabolic alkalosis, the patient's body will try to do a compensatory respiratory acidosis. And to do a compensatory respiratory acidosis, the body will try to retain CO2 inside the body. Okay, carbon dioxide jama karegi body andar. That will cause respiratory acidosis, and that will somewhere try to normalize the pH of the body. Okay? So here definitely if the body will do respiratory acidosis, it will try to increase the PCO2 values. Okay? And the PCO2 values are increased so much that the pH has been normalized now. Okay? So the pH has been balanced out because there is a metabolic alkalosis and there is a respiratory acidosis. So now both of them have normalized the values of the pH. Okay? So therefore it is called as totally or a fully compensated acid-base disorder. Okay? I hope this is fine with everybody. Now let's solve some questions, then you will get a clear idea what it is. So these are mostly the recall questions. So let's see. So if further before I move ahead, I hope so I'll just give you the causes of this. That would make everything simpler ahead. Okay? So first of all, if I talk about respiratory acidosis in a patient, what are the causes of respiratory acidosis in the patient? The first one. So please remember, respiratory acidosis can be caused by something like COPD, chronic obstructive pulmonary disease. Okay, and COPD, definitely the patient would be hypoventilating, and if the respiratory rate goes down, definitely the patient will have accumulation of CO2 that causes CO2 narcosis, finally leading to respiratory acidosis. Okay. Next, if I talk about, definitely one of the important causes of respiratory acidosis is respiratory center depression. So the respiratory center which is present in the central nervous system, if it is depressed, so this respiratory center depression can occur via multiple mechanisms. It can be due to some drugs which will depress the respiratory center, are drugs like opioids, mainly the drug which is known as morphine. It is known to cause respiratory center depression. Apart from that, some drugs like magnesium sulfate. As we know, in cases of magnesium sulfate toxicity, there is depression of the respiratory center that can lead to respiratory acidosis in the patient. Apart from this, definitely either a cardiogenic or a non-cardiogenic pulmonary edema. So cardiogenic pulmonary edema is definitely caused by CHF, congestive heart failure, whereas a non-cardiogenic pulmonary edema, which is an important cause of respiratory acidosis, it is caused by ARDS, acute respiratory distress syndrome, right? Apart from this, definitely the conditions of lung, like pneumoconiosis. Okay, so occupational lung diseases or pneumoconiosis is also an important cause of respiratory acidosis, and definitely CVA, that is your cerebrovascular accident. So CVA, as we know, they are nothing but strokes. So either a ischemic or a hemorrhagic stroke, which will decrease the blood supply to the respiratory center, causing its depression again, can also be one of the important causes of respiratory acidosis. Okay. Apart from that, definitely some CNS lesions. It can be something like toxoplasmosis. It can be something like encephalitis, meningitis. All of these can be a causes, and definitely something like which will cause paralysis of your respiratory muscles or your diaphragmatic paralysis. So conditions which will cause diaphragmatic or respiratory muscle paralysis, they will decrease the respiratory rate of the patient, and definitely therefore it will cause accumulation of CO2 inside the body, causing respiratory acidosis in the patient. Okay? So any neuromuscular junction disorders, it can be diseases like myasthenia gravis, it can be something like amyotrophic lateral sclerosis, ALS, it can be something like infections like poliomyelitis or even tetanus. So all of these are important causes. Even organophosphate carbamate poisoning, OPC poisoning, can be one of the causes of respiratory acidosis in the patient. So please remember always, respiratory acidosis is mainly caused by conditions which will tend to decrease the respiratory rate, causing accumulation of CO2 inside the body. Next, if I talk about respiratory alkalosis, the second condition. So respiratory alkalosis is usually caused by high altitude pulmonary edema. Okay, so please remember, whenever a patient is traveling on a mountain, okay, so what do we call that? Called as mountain sickness. So when a patient escalates a height more than 2,000 meters, definitely there is a high risk of high altitude pulmonary edema, which can be one of the important causes of respiratory alkalosis. Apart from that, definitely congestive heart failure, which can lead to cardiogenic pulmonary edema in the patient. Even apart from that, pulmonary embolism, bronchial asthma. Okay, so these are important causes which can lead to respiratory alkalosis in the patient. Flail chest. So flail chest causes paradoxical breathing. So initially, it definitely causes respiratory alkalosis. Okay? So flail chest is also an important cause of respiratory alkalosis as well as acidosis. Later in stages, it causes acidosis. Okay? Apart from that, definitely sepsis. Sepsis can be important causes of both again. Okay, so all of these you need to remember, guys. These are important causes of respiratory alkalosis, as I told you. Next, the third condition that we need to remember is metabolic acidosis. Metabolic acidosis, we will discuss about the causes, but please remember, usually metabolic acidosis can be a normal anion gap metabolic acidosis or a high anion gap metabolic acidosis. Depending on that, there would be causes. The causes of metabolic acidosis can be something like diarrhea, it can be renal failure, or it can be something like renal tubular acidosis, it can be fistula, or it can be even lactic acidosis or diabetic ketoacidosis, toxins like methanol or ethanol or ethylene glycol poisonings. So all of these, we'll discuss about metabolic acidosis in properly. Sorry. Apart from that, the fourth condition that I told you is metabolic alkalosis. So metabolic alkalosis, it can be caused by conditions like either a primary or a secondary hyperaldosteronism. So what happens in primary or secondary hyperaldosteronism? There is increased levels of mineralocorticoids like aldosterone. And as we know, what is the function of aldosterone? So aldosterone is known to retain water and sodium inside the body, and it tends to excrete out H plus ions and potassium ions out of the body. So it can cause hypokalemia on one hand. Along with that, it is also known to cause metabolic alkalosis in the patient because it excretes out the H plus ions. Okay? So please remember this. Okay? Apart from this, definitely apart from that, definitely excess of diuretic use. Okay, so excess of diuretics would also excrete out H plus ions, causing metabolic alkalosis in the patient. Chronic vomiting in a patient. Why? Because chronic vomiting, as in cases of congenital hypertrophic pyloric stenosis, CHPS ke bacche mein. So when there is a chronic vomiting, what happens? Usually all the HCl or acid from the stomach is excreted out. If that HCl is excreted out, there is loss of H plus ions from the body, and that can be important cause of metabolic alkalosis in the patient. Okay? So chronic vomiting, excess of diuretics, all of these, and hypokalemia. As I discussed in the electrolyte lecture, as I always told you, H plus ions and K plus, that is potassium, always go hand in hand. So अगर potassium बढ़ेगा तो H plus ions भी बढ़ेंगे. So in cases of hyperkalemia, the patient might suffer from metabolic acidosis, whereas in cases of hypokalemia, the patient might suffer from metabolic alkalosis. ठीक है? So all of these are important conditions, guys. You need to remember. Let's discuss further now. I hope all of you are clear about the causes now. Here they say a patient of COPD, chronic obstructive pulmonary disease, presents to the emergency room with exacerbation of breathlessness. He was drowsy. Why he was drowsy? Definitely the patient might have some CNS manifestations as drowsiness. Why? Because the patient might have altered sensorium or drowsiness because of accumulation of CO2. Because if CO2 accumulates in excess inside the body, it can cause CO2 narcosis. Okay. And if the patient suffers from CO2 narcosis, the patient might have drowsiness or altered sensorium as well. Okay. Yaad rakhna. Then the respiratory rate of the patient was 10 per minute. Normal respiratory rate is usually 12 to 16 breaths per minute, or you can just say 12 to 20 breaths per minute maximum. But here, the respiratory rate has gone down. It is usually 10 per minute. Definitely, the patient is having hypoventilation. The patient is having a decreased respiratory rate or hypoventilation. And as we know, if the patient is having a decreased respiratory rate or hypoventilation, there would be what? There would be accumulation of CO2 inside the body. Okay. And the accumulation of CO2 inside the body is also the cause behind this drowsiness. Okay. SpO2 was 65%. So if we check from the pulse oximeter, definitely the saturation of this patient would go down. It should be more than 94% normally, but here it is around 65%. That means definitely the PaO2 levels would be low, as you can see in the ABG as well. Apart from that, the BP was 120/70, which is normal. ABG was performed and sent for analysis. Definitely, we are suspecting if the patient is suffering from COPD, the respiratory rate is low, the patient has drowsiness, the SpO2 is low. Definitely, we need to do a ABG to check if the patient has some acid-base disorder. And therefore, the sample was sent for ABG analysis, and the ABG values are given as below. What are those? So here you can see the pH is 7.2, the PCO2 value is 88 mm of Hg, and the PO2 value is 40 mm of Hg, and the bicarbonate values are 25 milliequivalents. So I hope all of you are able to rule this out. PO2 40 mm of Hg, definitely if the patient is having hypoventilation, PO2 values are tend to go down because the patient is having hypoxemia as well. Okay? So PO2 is not of very much importance. We need to focus on the other three components as we have discussed in the earlier table as well. So if the pH is less than 7.35, here it is 7.2, definitely, which is the acid-base disorder the patient is suffering, definitely the patient is suffering from acidosis. Okay, if the pH is less than 7.35, definitely the patient is having acidosis. So let's see whether he is having a respiratory or a metabolic acidosis. So here you can see that the bicarbonate values are 25 milliequivalents, and the normal bicarbonate value is 22 to 26 milliequivalents per liter. So definitely the bicarbonate values are normal. So if the bicarbonate values are normal, definitely you need to check for the PCO2 values. Here PCO2 values are increased. Normal PCO2 value is 40 mm of Hg, and here the PCO2 value is 88 mm of Hg. Why? Because as the respiratory rate goes down, I told you there would be accumulation of CO2 inside the body, causing CO2 narcosis in the patient, and here the PCO2 values would be highly elevated, which is around 88 mm of Hg. So definitely it explains if CO2 values rise, definitely the patient will have acidosis. And as this acidosis is due to the respiratory component or the CO2 component, definitely the patient is suffering from which acid-base disorder? Here the patient is suffering from respiratory acidosis. This is how you come to a diagnosis of the patient. Okay? And if COPD hota hai, so it is more likely the patient is suffering from respiratory acidosis. Okay? No issues with this, anybody? So please remember. And here, if they would have given that the patient is having a bicarbonate value of around 34 milliequivalents. So agar bicarbonate value is बढ़ रही hai, that means the patient is having metabolic alkalosis. So if the patient is having respiratory acidosis and a compensatory metabolic alkalosis, so then it would be called as a partially or a totally compensated, depending on the pH values. So if the pH values is still less than 7.35, it would be called as a partially compensated respiratory acidosis. And if the pH values would have been normalized to 7.35 to 7.45 after increase in the bicarbonate values, then definitely it would be called as a fully or a totally compensated respiratory acidosis. No issues with this. If you need to remember, guys, please remember, usually if the patient is having respiratory acidosis, if it is acute respiratory acidosis, every 10 mm rise in the PCO2 values will increase the will increase the bicarbonate values by 1 milliequivalent. Okay, every 10 mm rise in the PCO2 values will increase the bicarbonate values by 1 milliequivalent per liter. Whereas in chronic conditions, in chronic respiratory acidosis, please remember every 10 mm rise in PCO2 values will increase the bicarbonates by 4 milliequivalents per liter. Okay, it will increase the bicarbonates by 4 milliequivalents per liter. So if the patient is having acute respiratory acidosis, and if the PCO2 value of this patient is 50 mm of Hg, that means 10 mm of Hg is more. Definitely the bicarbonate values would be around 27 milliequivalents. Why? Because the reabsorption of bicarbonates has been started by the body now. Okay? No issues with this. So please remember. And vice versa goes for alkalosis as well. If the patient is suffering from, if I'll just say, if the patient is suffering from respiratory alkalosis, please remember, if the patient is having a acute respiratory alkalosis, definitely every 10 mm of Hg decrease in PCO2 value, every 10 mm decrease in PCO2 values will decrease the bicarbonate values by 2 milliequivalents, will decrease the bicarbonate values by 2 milliequivalents per liter. Whereas in chronic respiratory alkalosis, in cases of chronic respiratory alkalosis, every 10 mm decrease in PCO2 values, every 10 mm decrease in PCO2 values will decrease the bicarbonate values by 4 milliequivalents per liter. Okay. So please remember, no issues with this. I hope so. If you are not able to remember this, at least for the FMG aspirants, no issues with that. NEET PG aspirants might need to remember this. Okay? So please remember, no issues with this. So at least I hope diagnosis would become easier now. At least तुमने ये तो diagnose कर लिया कि the patient is having respiratory acidosis, and that is more than enough. ठीक है? Next question says, this was also a recall question of FMGE. The patient was to be kept on ventilator. Which among the following? Okay. So it was the same case. Okay. The same patient of COPD presenting to ER with exacerbation of breathlessness. He was drowsy. Respiratory rate was 10. SpO2 is 65. BP is 120/70. ABG was performed. Shows pH of 7.2. PCO2 of 88. PaO2 of 40. And bicarbonates of 25 milliequivalents per liter. Definitely the acid-base disorder that we diagnosed is respiratory acidosis. So now the patient has to be kept on ventilator, right? Which among the following settings are to be made, or which of the following changes are to be made in the ventilator settings? So I hope all of you are quite aware. If a patient is suffering from respiratory acidosis, what is the treatment? Definitely the treatment in this patient would be a intubation. Here you need to intubate the patient. Elective intubation is done. Along with that, we will start IPPV, that is intermittent positive pressure ventilation, and the patient would be started. And therefore, the patient is to be kept on ventilator. So which of the settings would be done? So if the patient is suffering from respiratory acidosis, that means the patient would be more likely in type 2 respiratory failure. I hope all of you are quite aware. If there is decrease in, so please remember, in any type of respiratory failures, the PO2 values will go down. In any type of respiratory, I have discussed respiratory failures in pulmonary medicine, okay? If in any type of respiratory failures, definitely the patient is having a respiratory failure, that means the PO2 levels, okay? The partial pressure of oxygen will go down in the blood. So the PO2 levels would be low in any type of respiratory failure. But if the PCO2 values you need to look for, if PCO2 values, okay, please remember. So if the PCO2 values are either normal or they are decreased, okay, so PCO2 values are either normal or they are decreased, then it is a type 1 respiratory failure. So if PO2 value and PCO2 values are decreased, definitely it is a type 1 respiratory failure. Whereas in type 2 respiratory failures, the PO2 values are low, whereas the PCO2 values are high. The PCO2 levels values are high. We have discussed about all causes of type 2 respiratory failure, and one of the important causes of type 2 respiratory failure is definitely COPD, chronic obstructive pulmonary diseases. Okay, that is your chronic bronchitis is an important cause of type 2 respiratory failure, which causes accumulation of CO2 inside the body, causing type 2 respiratory failure in the patient. So here the patient is suffering definitely from type 2 respiratory failure, and what is to be done in this condition? If the patient is having respiratory acidosis or type 2 respiratory failure, whatever they give you in the question, definitely as the patient is hypoventilating, we know in cases of type 2 respiratory failure, the patient is having a decreased respiratory rate. Okay, the patient is having a decreased respiratory rate, guys, please remember, and therefore there is accumulation of CO2 inside the body. There is accumulation of CO2 inside the body, and that is what causes that is what causes the patient to land up in type 2 respiratory failure. Okay, please remember this. So if the patient is having type 2 respiratory failure, you definitely need to increase the respiratory rate in this patient. Once you increase the respiratory rate in this patient, what would happen? definitely if you increase the respiratory rate, the patient would be hyperventilating with the help of the ventilator, and therefore as the patient hyperventilates, the CO2 would be washed out of the body. Okay, so the CO2 would be thrown out of the body or washed out of the body, and the patient would normalize. Okay, so please remember, type 2 respiratory failure, what is to be done? Increase the respiratory rate. Whereas you would say, why not increase PEEP or increase FiO2? So please remember, guys, here the main culprit in type 2 respiratory failure is CO2. So try to get rid of that CO2, and that is done usually by increasing respiratory rate or by hyperventilation. Okay, so done with that. Increasing PEEP and increasing FiO2 are important things, but they have to be done for type 1 respiratory failure. Okay, please remember. What do we mean by PEEP? PEEP is positive end expiratory pressure. Okay, so this positive end expiratory pressure, that is PEEP, will help the alveoli to be patent during expiration. So क्या होता है usually expiration में the alveoli collapse. But if you need to keep the alveoli patent even during expiration, that is usually done by maintaining a high PEEP inside the patient. Okay, अगर तुम PEEP बढ़ाओगे, definitely the alveoli would be patent even in the phase of expiration. And क्यों उसको patent रखना even in expiration? Because there will be some exchange which would be occurring. Okay, so definitely, if we need to increase the PO2 value, we need to increase the oxygen exchange, and this oxygen exchange can be increased. Exchange can be increased by increasing the PEEP inside the patient, which will keep the alveoli patent even in the expiratory phase. So alveoli को ज़्यादा time मिलेगा usually in the inspiration as well as expiration, and therefore the oxygen exchange would be better. That will help to overcome this type 1 respiratory failure in the patient. Whereas if I talk about increasing FiO2, definitely what is the main problem? There is decreased PO2. PCO2 एक तो normal है या फिर थोड़ा बहुत decrease है. The main problem over here is actually decrease in PO2. And definitely if the patient is having decreased PO2, definitely try to increase the fractional inspiratory oxygen capacity. So that is what is FiO2. So try to increase FiO2. So increasing PEEP and increasing FiO2 for type 1 respiratory failure, whereas increasing respiratory rate for type 2 respiratory failure. ठीक है? Next question says, a patient was suffering from severe diarrhea and now was brought to the emergency room. Which of the acid-based disorder will the patient be most likely suffering from? So here, if the patient is having severe diarrhea, as I discussed, diarrhea is an important cause. Diarrhea is the important cause of metabolic acidosis. Why? Because whenever a patient is having diarrhea, there would be excretion of bicarbonate. क्या जाता है usually in diarrhea? The patient would excrete out mucus, right? So mucus is excreted out from the intestine, and this mucus, when it is excreted, this mucus contains high amounts of bicarbonates. So if bicarbonates are excreted out of the body, definitely the patient will suffer from acidosis. And as it is due to a metabolic cause, it is called as metabolic acidosis. So here definitely the most likely acid-based disorder the patient would be suffering from is metabolic acidosis. As I told you, there would be two types of metabolic acidosis, where either it is a normal anion gap metabolic acidosis, okay, normal anion gap metabolic acidosis, or it is a high anion gap metabolic acidosis, So for NAGMA or normal anion gap, here definitely the causes for normal anion gap metabolic acidosis are remembered as Dr. Fuse, that we have discussed even earlier as well. Okay, so the causes are remembered as Dr. Fuse. Where D, please remember, D goes for diarrhea, usually severe diarrhea. Then R goes for renal tubular acidosis. Usually. Okay? F goes for fistula. And U goes for uretrosigmoidostomy. Okay? So all these conditions are known to cause normal anion gap metabolic acidosis. Whereas high anion gap metabolic acidosis is caused by conditions known as CULT. Where K goes for ketoacidosis. So please remember, ketoacidosis can be seen in cases of severe starvation, or it is definitely also a complication of diabetes mellitus. Okay, it is also a complication of diabetes mellitus, which is called as diabetic ketoacidosis. That can lead to high anion gap metabolic acidosis. Why? Because there is increased levels of H+ ions inside the body. Okay. Next, definitely U goes for uremia. What do we mean by uremia? Uremia means renal failure. Uremia is due to accumulation of urea or nitrogenous substances inside the body, and that is definitely caused by renal failure. If the kidneys are not able to excrete out that excess of urea or nitrogenous waste from the body. Okay? Then L goes for lactic acidosis. So there are two types of lactic acidosis, type A and type B lactic acidosis. Please remember. Okay? So that you need to remember. So one of the lactic acidosis is definitely caused by drugs like biguvenides, which are used as oral hypoglycemic agents in diabetes mellitus. drugs like metformin or fenformin are known to cause lactic acidosis in the patient. Okay, please remember. And T here goes for toxins, definitely. And which type of toxins are known to cause metabolic acidosis? These are toxins like methanol, that is methyl alcohol. So methanol, or toxins like ethylene glycol, So either methanol poisoning or ethylene glycol poisoning are known to cause metabolic acidosis in the patient. That is high anion gap metabolic acidosis in the patient. Okay, no issues with this. And definitely they usually try to ask you about the treatment. So definitely if the patient is having metabolic acidosis, what is to be done? Definitely you need to treat the underlying cause. Whatever is the cause, try to treat that particular cause. But in emergency, if the patient presents to you, you will treat the patient by IV soda bicarbonate. You will treat the patient by IV soda bicarbonate. Definitely, you need to hydrate the patient properly. You need to start IV fluids in the patient. Along with that, if the patient is suffering from severe metabolic acidosis, you will definitely think in terms of IV soda bicarbonate, which is alkaline in nature. Okay? Moving further now, if I talk about the last question over here, a patient's ABG analysis shows a pH of 7.6, okay, PCO2 of 45 mm of Hg, and bicarbonates of 40 milliequivalents per liter. What is the most appropriate treatment option? Okay? So please remember, guys, here the pH is how much? So please remember, here the pH is usually more than 7.45. If the pH is more than 7.45, definitely the patient is likely suffering from which acid-base disorder? The patient is suffering from alkalosis. The patient is suffering from alkalosis. Ye to confirm ho gaya from the pH. Now you need to decide whether it is respiratory or metabolic. How will you decide? You need to look for PCO2 and bicarbonate values. Okay, so here you will see that the PCO2 value is 45 mm of Hg. So if PCO2 is increasing, that is suggestive of acidosis. If PCO2 increases, that is suggestive of acidosis. So this doesn't go in the favor of pH. Agar this doesn't go in the favor of pH, so definitely this is a compensatory mechanism. Ye ulta ho raha hai na kuch. So definitely this is for compensation. Okay, so this is not the main cause or the underlying cause. So what is the main cause? Here you can see that the bicarbonates are favoring the pH value. So yaad rakhna hamesha how to decide whichever component favors the pH value would be the likely cause. Okay, whichever component. If the pH is showing acidosis and the PCO2 is also showing acidosis, definitely it is a respiratory acidosis. Okay? If the pH is showing alkalosis and the bicarbonates are also showing alkalosis, then definitely it is a metabolic alkalosis. Okay? So the pH values are the most important ones which will decide the acid-base disorder. And then you need to look for which among the two, that is PCO2 or bicarbonates, will favor the pH. जो भी pH को favor करेगा, that is the likely cause for that particular acid-base disorder. ठीक है? This is how you decide. Not depending on CO2 and bicarbonates, you will decide. ठीक है? Depending on pH, you decide. The most important thing is pH in the patient. ठीक है? याद रखना हमेशा. pH के लिए जितनी भी मारामारी हो रही है ना, that is for your pH, not for your PCO2 or bicarbonate values. वो ऊपर नीचे हो तो चलेगा, pH normal रहना चाहिए. That is more important. ठीक है? So here the patient is having bicarbonate values of 40 milliequivalents. So if they are more than 26 milliequivalents per liter, definitely the patient is having metabolic alkalosis. So here the more likely cause is metabolic alkalosis in the patient. So diagnosis ban gaya, metabolic alkalosis. So what is the most appropriate treatment option for metabolic alkalosis? So please remember, most of us are very sure about soda bicarbonate for metabolic acidosis, but most of us tend to forget what we give usually in metabolic alkalosis. If the patient is having metabolic alkalosis, here you need to give some acidic component to the patient. So definitely you tend to give ammonium chloride to the patient, okay, which is acidic in nature. So IV ammonium chloride is usually started in this patient if the patient is suffering from metabolic alkalosis. If the patient is suffering from metabolic alkalosis. और यहाँ पे कैसा type का acid-base disorder? Definitely we diagnosed it as a metabolic alkalosis. Okay, it is a metabolic alkalosis. Okay, because pH is also alkaline and bicarbonate values are also high, that is 40 milliequivalents. But why the PCO2 values are rising? Yes, PCO2 values are rising. They are turning acidic because the body is trying to compensate now. So this is definitely a partially compensated metabolic acidosis. Why I'm saying partially compensated and not fully compensated? Because the pH value has not been normalized yet. Agar pH value normalized hoti, it would have been between 7.35 to 7.45. तो मैं बोलता fully compensated. But यहाँ पे pH value अभी तक abnormal है. Therefore, I am saying it as a partially compensated metabolic alkalosis, or sometimes I would also say a metabolic alkalosis with a compensatory respiratory acidosis. ठीक है? No issues with this. And sometimes the question can be like, so please remember, here I will give one example and you will tell me what is this condition. So here the patient's pH is around 7.2. The patient's PCO2 value is around 85 mm of Hg. Okay, the patient's PCO2 value is around 85 mm of Hg, whereas the patient's bicarbonate values are somewhere around 16 milliequivalents. So यहाँ पे patient को क्या है, definitely if the pH is 7.2 less than 7.35, the patient is having acidosis, right? Which type of acidosis? Let's see. Here, the PCO2 values are more than 40 mm of Hg, it is around 85. Definitely, it is respiratory acidosis. But look now, the bicarbonate values are also less than 22 milliequivalents. That means if the bicarbonate values are low, definitely it is also suggestive of metabolic acidosis. So here, please remember the patient is having both. The patient is suffering from respiratory as well as a metabolic acidosis. The patient is suffering from both respiratory as well as a metabolic acidosis. So some conditions can appear like this, जहाँ पे both of these things are going in the favor of the pH. If both the things go in the favor of the pH, okay, then definitely it is both respiratory as well as metabolic acidosis or alkalosis, whatever it is. Okay, so please remember such conditions can also occur at times, but more likely it is usually they will ask you these 4 most important conditions, only the 4 ones, या फिर कभी कभी वो compensated पूछेंगे, और compensated में हमेशा याद रखना usually whichever value goes in the favor of pH, that is the underlying acid base disorder, whereas whichever value goes opposite to the pH, that means it is a compensatory mechanism activated by the body. Okay, no issues with this. I hope all of you would be very thorough with this ABG analysis now. So thank you so much. I hope so. If you haven't started your preparation yet, guys, get back to your studies now. This is the time. Okay, so it's better that you start earlier so you have more time for your preparations, and definitely it is important to maintain your consistency and your patience throughout, because if you lose your patience and your calm in your preparations, definitely that is going to hamper your preparation somewhere, because this is a long 4 to 5 months journey. So don't get exhausted in the initial days. यहाँ पे अभी 10-10 12-12 घंटे बैठ के कुछ नहीं होने वाला. So always try to maintain a pace, as I've always told you. Try to maintain consistency and be patient. Result भी नहीं आया तो आ जाएगा जल्दी. Okay, so don't worry about that even. So just maintain your calm, maintain your peace, and thank you so much. Let's meet in another session of high yielding topics. Till then, goodbye and good luck.